Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
Dr. William Leone, we were talking about you. Dr. Mencia actually said that he wanted to say hello. So, good morning, Dr. Leone.
Well, good morning. Thank you once again for inviting me. I'm always honored.
Yes, I'm. Of course, I hope that you would be in my studio because I always like to see your pretty face. But that's okay. We'll do it this way. And I am so glad to talk to you now because there are so many things coming out from orthopedic organizations about how to fix knees and hips. And you're, of course, for me, the guru. So I don't know how you feel about all this, but I guess things just keep moving on, don't they?
You know, it just is really remarkable. I've now been quite remarkably doing this for 25 years, just, focusing on hips and knees, and just in Fort Lauderdale, Boca Raton area, and just at Holy Cross. And when I really look at, I think the biggest changes in my 25 years of doing it, it's how much faster people get well. And we're not kicking them out of the hospital. They're really getting well. And I think that's because we're doing such a better job with letting people know what to expect before the surgery, with truly managing their pain by preventing it or diminishing it greatly after surgery. And it's just made a huge difference. So they want to go home much quicker and they get back in their lives much quicker. And because we're so much more experienced with what we do, so much of what we used to advise people in terms of don't do this and it's important to do that, so much of that's just gone away, where now people just very quickly get back to a more normal activity and stop thinking about it.
It probably was the fear factor, though, many years ago, too, wasn't it? They were so afraid. And when you go into surgery and you've been afraid, it probably isn't the best thing either, but they've seen their friends go in and come out and doing so well.
Yeah, well, it was there was so much fear about blood clots, and now, of course, by mobilizing people so much faster and having a better understanding what we can do mechanically and chemically with the different meds to prevent it, and better surgery, so we're not traumatizing the tissue. The incidence is so much smaller, and our infection rate. It's all been really a real move forward. But I think the greatest things has been our ability to diminish the anxiety and the discomfort postoperatively by really diminishing and controlling pain.
Well, you've been such an expert at this, and so it's been, I'm sure, very rewarding for you to see people like my husband who's had hips and knees for so many years, and he just keeps functioning. And, years ago, people were, I guess they were destined to be in wheelchairs. They didn't have the kinds of knowledge and experts like you are.
As little as, 60 or 70 years ago, truly, people, this was what condemned them to a life of immobility, and then all sorts of other problems would happen. Or if somebody broke their hip, people died from it because they could no longer get out of bed and be functional, and they got blood clots and their skin broke down and they got pulmonary emboli. And all this has just changed in a very, very positive way. And we're so blessed in this country because now we take so much of this for granted. No matter what's happening in your world, you always complain and think it can be better, and it can be. But I was just reading a little something about what's going on in Canada and the wait times compared to, what we wait for here. In terms of if there is a problem, the availability of so many wonderful experts around that can help, and if something actually needs to be done in a hospital or with a procedure, it's not a 6-month or 2-year waiting list. It just happens.
Let me ask you a question. I'm glad you brought that up. So let's say there's that person waiting a long time, and it's not so much that they can't get a doctor to do this now, but they just keep putting it off, and they have all sorts of reasons. They're too busy, or they have to lose weight first, or something. Now they're on medication for pain because, they're in pain. Let's say now they go and have this fixed, could they have become addicted to that pain medicine?
especially in the United States now, and particularly South Florida, the incidence of people dependent on narcotics is at an epidemic proportion. And it's a lot of it's because it was mandated a decade ago that this would be the decade of pain control. And so we were so much more stingier with our narcotics, and the dictum came out that people should not be in pain. And so a lot more narcotics were written for, and the pharmaceutical companies, of course, then created all these wonderful different narcotics and combinations, and now we have a huge population of people that are addicted, and now, of course, we're trying to go the other way. So it's a pendulum. So the real question is, you need to, first of all, pain meds do not get rid of all the pain, but they can certainly dull it tremendously and make it more tolerable. And if there's a chronic condition like an arthritic hip or an arthritic knee that's not just going to go away, unfortunately, the natural history is it'll get worse, then you don't want to be taking narcotics for that, because, of course, what happens is our body develops, and not an immunity, but in essence, the receptors that they bind to become less sensitive, and it requires more and more of it just to get the same effect. And they have other effects because they make you feel depressed, and they suppress our own natural hormones or our own natural endorphins. So it's a real slippery slope. So the real question is, when is it appropriate to do something? And, of course, we're people, so there's no one answer. But as a surgeon trying to solve a problem, it's much more satisfactory and predictable to solve something when it's not as severe as when it's one of those, oh, my goodness, I can't believe you've been able to wait this long and you're this disabled. Joint replacements are just a remarkably powerful and predictable way to solve a problem and get rid of pain, but there's more to it than just pain. There's function. And although function will improve greatly, it can only improve to a degree. If you're that disabled before surgery, does it ever fully recover to the degree that it would have if you would have had the joint replaced sooner? And it doesn't. Maybe that's good enough for that individual person. So it really becomes a personal choice when to do something. In all of our lives, everyone is always too busy, and there's never a good time. It's like having a baby. But on the other hand, there's a point where you start looking at all the cards, and it's requiring narcotics or different, powerful medicines to go to sleep, and you're giving away more and more activities. It just does become appropriate. What I'm seeing more and more in my practice is a group of people that come in very frustrated because they're giving up a lot of activities that they may enjoy, be it walking after dinner or playing golf or really being more active, playing tennis or going dancing or getting up after a business meeting and just walking, and they do have a diagnosis of a problem with either their hip or their knee, and they've been down that path of seeing a doctor or a number of different doctors, and have been, very appropriately, evaluated either with plain radiographs or with an MRI scan, and they, very appropriately were treated with, a variety of different medicines, the non-steroidals or the Tylenols or the modalities with ice and heat, or maybe therapy or braces, and maybe even they've had, a hip or knee arthroscopy. But, when they see these other doctors, everyone kind of tells them that, yeah, it's coming from your hip or your knee, but you're only this old maybe, and the X-ray doesn't look that bad. There's still pretty good cartilage between the bones, or the femoral head is still round, or the femoral condyles are still nice and smooth, but yet they're miserable. And maybe they've tried the hyaluronic acid injections, and now they're really reaching, and they're trying the PRP or some of the other things that we're kind of learning about. So, there's definitely a subclass of people, and I see a number of these, that are actively seeking to fix what's wrong with them, but they're being told, they've been given the message by healthcare providers that, yes, it's coming from their hip or knee, either that they're too young or that their x-rays, quote, don't look that bad. And, a lot of these people, when I actually operate on them, and I do operate on them, what I see is more severe arthritis, and I see visually pathology within the hip or knee that really explains why they were doing that bad. So the x-rays always don't go hand in hand with how disabled someone feels. And in our modern day world where we depend so much on the blood test, or we depend so much on the MRI scan or the image, I keep falling back on really talking to people and getting a real history to kind of get a feeling how disabled they're becoming with something and how long it's been going on, and then really trusting my physical exam. I see young people being trained now to be healthcare providers, and certainly the emphasis is on data collection with all the EMRs and ordering the next test and what that means and making sure it's documented. But it's not necessarily on really getting a history, not just filling in the bubbles on a sheet for the computer for someone else to look at or to code, and really doing a physical exam. And it's like anything, it's practice. And if you practice enough, you develop a tremendous amount of confidence in your physical exam and your history taking and your whole feeling of what's happening with the patient, that then despite an x-ray that, quote, doesn't look that bad, if I replace part of their knee or all of their knee or part of their hip, I'm finding that these are some of the most grateful people because they're saying somebody's listening to me. And I think in our world with all this noise and all this computerization and all this standardization and all these following templates, we can't lose that. It's still very, very much an art. It's easy when someone is a senior citizen and someone now is got a very obviously arthritic hip or knee with deformity, and they've had the therapy and had the anti-inflammatories. But what do you do with the person that doesn't fall into that category, and their x-rays, quote, don't look that bad, but their life is on hold, and they're in a tailspin. And those are some of the most grateful people I'm seeing. The others everyone agrees on. These takes more confidence, a little more controversial, but they're very grateful.
Well, let me attest to what Dr. Leone said, of course, and I've talked about this before. Then anyone asks me who they should go to, of course, for their knee and hip operation, it's always Dr. William Leone, because my husband has had that experience. But let me tell you, Dr. William Leone is head of the Leone Center for Orthopedic Care at Holy Cross Hospital. He specializes in partial and total hip and knee replacement and revision surgery. That's another discussion we're going to have. And knee arthroscopy. The Leone Center is located at the Holy Cross Health Plex, which is over in Fort Lauderdale. You can reach him you can, let's see, I don't have his office number, but you can go online, which is holycrossleonecenter.com. Is that good enough, Dr. Leone? Holy Cross Leone Center?
Yeah, or the office number is 954-489-4575. And I'm part of the Holy Cross Orthopedic Group. I was truly one of the people that really was one of the initial people that started it with Holy Cross. So I'm really proud of it. And, maybe I'm prejudiced in saying that, but I really think it's one of the true gold stars that has put Holy Cross on the map. And we just take so much pride in it, and it just seems to get better.
Well, you've certainly done a lot. And now maybe we ought to talk about revision surgery, because that's another whole world, isn't it? And you have become so popular and so well thought of in this area that doctors, orthopedic surgeons themselves refer Dr. Leone, because it's such tough job, and someone's got to do it.
Well, it's like anything else. If you build a house, it's one thing to build it with fallow ground and starting from the ground up, and it's another to then take an old house and say, oh my goodness gracious, we got to keep this, and that's all we have left here, and how do we really build something that's still very structurally strong and beautiful? So, when you operate on someone for the first time, it's virgin anatomy, and it's much more predictable. And when you do, when you have to, for whatever reason, go back in and redo it, and sometimes for the fifth or sixth or eighth time, it becomes much more of a reach. And, I was very blessed that when I first came to town and I had this dream and this vision that I really wanted to be, this guy that was the hip and knee guy for this area, you don't start out getting all these people come to you that have pretty normal-looking x-rays and are giving you this history that they're miserable. You see all the cases that, nobody else wants. And so I truly cut my teeth, redoing all these hip and knees that, for whatever reason, had failed. When it comes to knees, I'm really getting into this population of people that have already had their knee done, and again, they fall into that same class of it looks good but feels bad, and where it still bends pretty good and the leg looks pretty straight, and everyone looks at their x-rays and they pat themselves on the back, but they're still really unhappy with it, or it just doesn't feel normal, or it doesn't feel stable. And these are patients that I'm returning back to the operating room. And now with the advent of some very new technology, I'm having a tool rather than just feel it with my hands and look at it with my eyes. I'm having a computer that can allow me to quantitate and really understand on a screen so I can see it, how it's loading and where it's loading and how it's moving. So rather than go in with the mentality of changing everything, like a modern-day mechanic who hooks their car up to a computer and then looks at the computer and the computer tells you which system is bad, I can much more key into which exact part of the knee I need to change. I operated on this really spiritual, really cool 68-year-old man on Monday. And he was only 4 months after his knee replacement, but he could barely walk from the car to my office.
Oh.
And I could see some technical problems on the x-ray, but it was grossly unstable. And just by using this system, I recognized that the femoral component was okay. I only needed to change the tibial tray. That's the part that sits on the lower leg bone, the tibia. Rebalancing it, recutting it, putting in blocks, re-putting in spacers. And he would home the next day, and it just makes your heart sing. We've been reading in the paper about these unfortunate people that had their hip replaced with a particular type of femoral stem, a primary modular hip stem, which is really being a bad player, where a very, very high percentage of the people with that stem are developing corrosion between the modular neck and the stem. And biologically, their bodies are reacting to these products with some sort of an abnormal local tissue response. And it's creating either big fluid collections, which we call pseudotumors, or these big solid soft tissue reactions, also a type of pseudotumor. And it's causing, and some people are having pain, and some people are having their abductor mechanism, the part of their muscles that insert into the upper femur and help stabilize the hip and let them, when they walk, not limp, be destroyed. So I've been really embroiled in this whole arena now of understanding this and trying to help this population. And I've really developed an insight and an expertise and a real producible methodology of removing the stems. I mean, when you just conceptually think about it, how does one remove a big, titanium implant, which the body has completely grown into, which is in the middle of our femur bones. And if you remove it, how do you have a femur bone left? And so it's again been very, very satisfying and a real learning curve, and something which I've now tried to help and teach some other doctors.
Dr. Leone, and so one thing that you and I've discussed before is the age of people. So if someone's 60, it's probably easier to do this than if someone is 90. Is that true?
Age is, this was a remarkable week, just a remarkably cool week, because I also got to operate on a 96-year-old, just one of the coolest ladies I've ever met. She doesn't even have wrinkles, on Monday. And I did a partial knee, and she went home on Tuesday, her daughter, just walking, and the internist walked in and said, don't you think we should keep her another day because of her age, and she's hypertensive? And, of course, she was hypertensive because she was in the hospital looking at all these white coats. I mean, I get it. So the whole philosophy with how, no, we're not doing her a favor keeping her in the hospital. She's much happier home. She's going to go to the bathroom. She's eating her own food. She can walk to the mailbox. So, and then on Monday, I'm actually going to operate on a lady who's 100.
Wait. Monday, you're going to operate on a 100-year-old woman?
And again, there's nothing wrong with her. She has better hearing than mine. I think my vision's a little better, but that's it. And she has hardly any wrinkles, and and her hip she's lost her ability to walk, so she's going to end up in an adult living facility unless we do something. And she wants me to take care of her. So age is not so much the chronologic age; it's the physiologic age. Mm. So I operate on some people that are 60, and they're a mess because they, whether genetically or lifestyle-wise, they've developed a whole host of medical problems that make them much higher risk. So yes, age is important, but there's a lot of other factors. It's important to not just preoperatively clear someone for surgery. It's not important that I just send someone to their medical doctor and say, tell me they're okay so legally I can go forward. How do you preoperatively optimize someone before surgery so that they're, so if there's a problem, we've like hypertension, like diabetes, like adult asthma, like bronchitis, or like anything, it's as good as it can be. So doing it after surgery, it's minimized, and we understand it, and it's defined.
You are great, Doctor.
We keep trying to get better at our game.
Dr. Leone, you are absolutely wonderful, and I definitely need to come by, sit and talk with you, and you just there's never a time that we do this that I don't sit here with my mouth open, and thank you. So I wish you luck on Monday with that wonderful lady, and we certainly appreciate you so much.
Well, the other part is Monday. I'm operating on a wonderful gentleman who I've known for 20 years, who has an aortic aneurysm. He has ureters that because he doesn't have a bladder that lead right from his kidneys. He's super, super high risk. But mentally, he's just solid and the patriarch of his family. And so it's also about taking people like that where do they go, and really putting together the right team so I can really take care of them.
Well, that's part one. What I
get to do is it's the whole spectrum of people, and just all...
Part one, Dr. Leone. We'll get to part two next time, so just save the stories, and we'll get back to you. And be sure to call Dr. Leone. Phone number's 954-489-4575. Thanks, Dr. Leone. Have a great weekend.
Thank you so very much.
All right, bye.